calendar year. We'll have one more in October, but we're delighted you could be on the call with us tonight. We like to remind everyone when we begin these programs each evening that we will be recording the program, audio and video, for use by our associates who are unable to be on the program to listen to the program tonight due to their clinical responsibilities. We do not publish or distribute these recordings as such, and it's only for internal use, if you will, for those who could not attend. If you have any concern about your participation in a recorded activity, we invite you to leave now. Your remaining with us is an implied permission that you're happy that it's being recorded. We are pleased to remind everyone that these programs are currently available to listen to on the Sovah Health website. If you click on the Education tab, you'll subsequently see a menu that lists the various programs we've done in the past several months. These programs are there for listening and watching only. They do not provide CME credit. They're not what are known as enduring materials in the CME world, but they're certainly there if you wish to do that. If you're internal on a hospital computer or device, if you want to listen there without going to the external web, just contact myself or Mary Kent, and we'll be happy to make that happen for you. The program this evening provides 1.5 hours of Physicians Category 1 CME. We are accredited by the Southern State CME Collaborative, of which the Medical Society of Virginia is a member. And as such, we can provide Category 1 AMA Physician CME credit. We also are providing 1.5 hours of Virginia Nursing Association CE credit, and we are accredited, the hospital that is, by the Virginia Nurses Association to provide that type of CME credit for nurses. This program tonight was developed to promote the following desirable physician attributes, including compassionate and appropriate patient care, interpersonal communication skills among healthcare professionals that fosters a warm and effective therapeutic relationship in order to care for patients. And finally, professionalism, which is a commitment to carrying out our responsibilities along ethical principles and being sensitive to diverse populations. Dr. Patch, Dr. Hill, our speakers, myself, and members of the Sovah Health CME Committee have no commercial disclosures to report to you this evening. This program does not have any commercial support. We are fortunate to be supported in our CME programming from the Ralph Landis Medical Education Fund, which resides at the Danville Community College Educational Foundation. This fund, which provides an endowment for medical education for all types of healthcare professionals in our region and our local area, was created when Dr. Ralph Landis, the founder of the Danville Urologic Clinic, or what's now known as Southside Urology and Nephrology Clinic, retired, and he provided a significant contribution to establish this program, which allows us to have speakers such as Dr. Hill and Dr. Patch tonight. This evening or in the morning, when Mary sends it out, you'll receive a link to a CME evaluation form. It contains 7 questions. We always remind you in answering those questions, and number 4 is one particularly important to us. It asks, what changes will you be making in your practice from what you learned this evening? We remind everyone, this is for everyone that gets an eval form, not just for the physicians. This is an important part of our accreditation process. This eval form requires you once again to provide your name, email, etc. We urge you to please put your real formal name there. We can't do nicknames or just one first name, if you will, because this links to your getting a CME certificate sent to you once you submit the eval form. The eval form is not required for you to receive a CME certificate or a CE certificate for your participation. If you would prefer not to do an eval form, if you'll contact Mary Kent through the email you'll see in a moment, we'll be more than happy to get the certificate to you. But when you do log on to the eval form, and we hope everyone will take the few minutes it takes to complete it, please give us your full name so we can get the certificate to you. If someone's with you as you log on, you're sharing, if you will, the log on with someone else this evening, please let Mary know about that so everyone can get credit. For the medical residents, we provide to your coordinator, that's Dara and Lori, your participation, so you do not have to collect CME certificates to document what's being required of you from your respective programs. I always like to thank Mary Kent, who is the CME coordinator for us, who does all the heavy lifting, who basically makes these things happen. And without her help, we would not be able to do the programs we do. Also, thanks to Vandora Holt, who is currently managing our nursing CE accreditation process. Those of you who are local and are aware of some of the hospital happenings, Camilla Deal retired after many years of wonderful nursing educational service a month ago or in this past month, and Van Holt is picking that up. So if you have any questions about anything about the program, feel free to contact any of us, and we'll do our best to answer your question. We do use, for the physicians on the call, the ACCME passport process. The ACCME is the accrediting organization for all physician allopathic CME in the United States, and they maintain a website known as the Program and Activity Reporting System, or PARS. Embedded within that is a physician service nicknamed Passport. So if you give us your permission, this is just the physicians, we will report your participation to Passport. You only have to give that once, so if you've already done that, do not worry about it. On the other hand, if you haven't, and we do have some physicians that are to be on the call tonight who this may be their first program with us at Sovah Health, the form at the end of the eval form will ask you for your name, your birthday, month, and the state in which you're licensed. You'll subsequently receive an email from us telling you that we have registered your participation in the passport system. That's in addition to your getting the CME certificate. I know the two speakers we have this evening would urge you and hope you will have questions or comments. They will actively try and hope to engage you. We urge you, when you ask a question, once you've stated your question, please mute your phone so we don't get feedback. You're welcome to as many questions, comments, whatever. The more you can participate, the better the whole program goes. Mary will also be monitoring the chat function on Teams. So if you want to send a question or message to the speakers that way, Mary will see that it gets straight on to them. I want to highlight our upcoming programs as we begin what will be the academic year, traditionally September through June. In about 2 weeks or so, on Wednesday, September 4th, and that's a Wednesday, not a Thursday, we're going to have a very special program with Dr. Argwal from the LifePoint, if you will, Health Support System office in Brentwood, Tennessee, talking about strategies to optimize inpatient care. This is going to be a discussion of best practices that enable patients to optimize the care in conditions such as sepsis, heart failure, etc. He'll be assisted by Dr. Sharonda Gunn Nolan, our chief medical officer. So I hope you'll be on for that. And then in September 12th, which is a week after that, we'll have an update from on adult vaccinations, annual adult vaccinations, what your patients will be asking about, what they'll be hearing about from the CDC about COVID and annual influenza vaccines with Dr. Cam Wolf, who's at Duke. Dr. Wolf's spoken to us many times before and is just a terrific speaker. And he'll be joined that evening by Dr. John Barata, who is at the University of North Carolina. And Dr. Barata is one of the national experts on long COVID. And he'll be talking about how that syndrome has come to be better defined, recognized, and there's actually some theoretical basis that's emerging that is interesting to hear him talk about that. And then finally in September, the last week, we will have a women's cardiovascular health update, talking about screening women for cardiovascular risk and evaluating them, particularly for coronary artery disease, chest pain, and acute myocardial infarction. Acute ischemic heart disease in women can be terribly hard to diagnose because it can present in so many different non-classical ways, meaning as opposed to the left arm heavy chest feeling that is said to be typical of an acute ischemic heart event. It can present with a myriad of symptoms, and it can be very hard to diagnose the severity of the disease. Oftentimes, the coronary artery cath is not diagnostic, yet there's serious small vessel, if you will, coronary disease in a lot of these women. So the two speakers we're having for that, Dr. Shah is Duke Cardiology, and Dr. Hashim is an interventional cardiologist with lots of experience on evaluating women's chest pain from Georgetown. So we hope you'll be part of that. So let me introduce the two speakers. We are so happy to have them tonight, Dr. Michelle Patch and Dr. Peter Hill. Dr. Patch is a part of the Johns Hopkins School of Nursing. She received her undergraduate degree at Marquette, and she did extremely well, receiving her BSN in nursing. She was selected for Sigma Theta Tau, which is the Nursing Honor Society. She then completed her PhD and her master's in nursing at Johns Hopkins University in the School of Nursing, and then went on to get a subsequent degree from Johns Hopkins on forensic nursing. And this is a very interesting skill set that she has had for a number of years. A forensic nurse basically provides comprehensive care to victims of violence and participates in the medical evaluation of the victim, also the collection and maintaining the evidence, the chain of information that's collected once this has happened. She then would provide courtroom testimony and helps with extremely challenging compassion, sensitivity, and helping the survivors of violence. She currently is a principal faculty member of the Johns Hopkins Armstrong Institute for Patient Safety and Quality, and she's the coordinator for the Doctor of Nursing, the PhD program for the Practical Clinical Nurse Specialist track at Johns Hopkins. She has published 9 book chapters, and her most recent academic, as far as publication accomplishments, includes her participating in the National Association of Clinical Nurse Specialists position paper on the use of simulation in clinical nurse practicum evaluation. Really a remarkable person. She's recognized nationally as an expert on our topic tonight. Our other speaker is Dr. Peter Hill, and you can see both of them on your screen now. Dr. Hill began his medical career, and I'm always pleased to share this with individuals. He began it as an Eagle Scout, and being an Eagle Scout is really if you're in the business of reviewing folks about how well they've done in their careers, Eagle Scout's a big deal because it shows that a young person can complete a goal they set and do it efficiently and effectively. His work in medicine later was recognized by the Boy Scouts of America as him being an outstanding leader in that area. He began his undergraduate career in geology, receiving his degree from the University of California, Santa Barbara, after some time at the University of Leeds in Britain. He subsequently received his master's degree from Brown University in geophysics and volcanology. That's studying of volcanoes. He's worked as a research assistant in volcanic programs. But in 1995, he went on to receive his MD degree at the University of Maryland in Baltimore, and then he did his residency in emergency medicine at the Johns Hopkins Hospital. He served as the chief resident among his during his residency program there, and his last year he was chosen as resident of the year. He has had 3 book chapters published. He has an extensive, I mean, page after page after page of teaching experience and expertise. He's a recognized international expert in the education of emergency room physicians. He also is a faculty member of the Hopkins Armstrong Institute for Patient Safety and Quality. He's Senior Vice President of Medical Affairs for Hopkins and is the Chief Medical Officer, the CMO, as it were, for the Hopkins Health System. The Hopkins Health System includes the original hospital shown on the slide below and the buildings that surround that, as well as numerous other hospitals in the greater Baltimore areas and the many Hopkins clinics. So we're just so happy to have these two folks with us tonight. Also, Dr. Patch was extremely helpful in us organizing this overall program, for which we're grateful. So Dr. Patch and Dr. Hill, I will take down my slides if I'm lucky, and if you bring yours up, I think yours will just knock me off and we'll go do it. Thanks so much.
Okay, thank you very much. We're going to give a shot here of getting the slides up correctly. I'm going to do that one. And yep, I think we're in.
I think you're good.
They look good.
They look good?
Excellent.
Yep.
Excellent. All right. First try. That's fantastic.
Wonderful. Yeah. Well, hi, everyone. It's so wonderful to meet you all virtually, of course. And thank you for that really warm welcome coming to you live here from Baltimore, from the Johns Hopkins Hospital in the Dome.
In the Dome.
In the Dome. And so I'm Michelle, and this is Peter. And we have actually worked together for how long? 16 years?
About that, yeah.
About 16 years.
Mm-hmm.
I was a safety officer in the Department of Emergency Medicine, and Peter was the medical director.
Correct.
And so together, we have worked for many years on patient safety and quality projects and patient satisfaction, service excellence, lots of different projects.
Yeah, absolutely. And these issues that we're going to talk about tonight came up from time to time. And of course, still continue to do so. I did want to pause and welcome a special welcome out to the house staff residents who are on the Zoom. Over the past 6 years, I had the opportunity really to be a physician executive in the hospital that interacts with the GME, and being a resident from this institution. I'm a PGY 26. So for those of you who identify yourselves as PGY 1, 2, 3, it does continue. So again, special welcome to you. And I know the Zoom with so many people on it, you can't see each other. It's difficult to have a conversation, but we do want to encourage that if you want to interrupt, if you would like to send a message in the chat, I think Mary's going to be looking at it, and Mary, feel free to interrupt us, and we can have that conversation. We have a number of slides prepared in a kind of route we want to do this.
Yeah.
But we don't have to go through all of them.
No.
Okay. So I just wanted to set that stage.
Absolutely, because we just thought, hey, let's prepare some things, but we want to allow for some space to have dialogue. And also a great welcome to those nurses and advanced practice nurses that are online. We're excited that you're here too. So our learning objectives are here on the screen. We're going to be talking tonight about inappropriate interpersonal behaviors, looking a little bit at their various manifestations, talking a bit about what are the drivers and the contextual elements that go into those, particularly in the healthcare environment, and then talking a little bit about the potential consequences and what we see in these aftermath ripple effects from them. And then at the end, we're going to talk a little bit about some management strategies for prevention and mitigation.
So we're going to go through the what, who, why, and how. Now, it's not going to be structured exactly like that. And we're going to weave some scenarios that you'll see as we go through to try to break it up a little bit and provide some context to some of these interactions and behaviors, and we hope that might generate some interest and thought as we talk, and we can stop either at the end or throughout just to talk about the scenario if you want. But certainly don't have to. But we thought that might be a little bit more fun way of going through some of this information. So we're going to talk about what are these behaviors that we're talking about, who might be involved, or who does it affect, why might it happen, and again, how we can address it.
Yeah.
All right.
So we have a variety of different organizations nationally that give us some guidance on what is conduct unbecoming. And as we look at them, we have the American Medical Association, the Joint Commission, the American Nursing Association, our Agency for Healthcare Research and Quality, our National Patient Safety Foundation, and all of them have definitions that are very similar. What we're talking about are verbal or physical behaviors. I'm sorry, I think, could someone mute? Thanks. Verbal or physical behaviors, right, that end up intimidating, disrespecting, or ending up having a problem around verbal abuse, physical abuse, potentially, but they affect patient care. They affect the workplace morale. And the collaboration and the ability of the team to really provide that great care.
Yeah, absolutely. We called out that in each one of these, there's patient care is highlighted, and wanted to highlight this idea of microaggression versus macroaggression, disruptive and unprofessional behavior. Everybody can understand that throwing things around, throwing things at people, screaming and swearing at somebody, threatening that you're going to hit them. Actually, physical contact with people, I mean, we all agree that all that's beyond the pale. I mean, that's pretty obvious. We're going to talk a little bit about more of the subtle things that can happen even on a daily basis. People sometimes label these as microaggressions, but they can be a little bit more overt. As disruptive, unprofessional, and we're going to get into a couple of different words in just a moment. Yeah, sure. So we labeled this as conduct unbecoming, from a military.
Yeah, I was in the Navy for a little bit.
Michelle was in the Navy, yes. And so when you read through the literature, there's a lot of talk about incivility and bullying. And is there a difference? I mean, they're both disruptive to the workplace, right? Incivility is kind of rude, discourteous actions, gossiping, spreading rumors, sort of refusing to assist a coworker, a little eye rolling, heavy sighing, things of that nature, and others. Bullying is this repeated, unwanted, harmful actions really intended to humiliate, offend, and cause distress in the recipient. So that's kind of how you can frame that in your mind.
And so, we've gone ahead and we've talked a little bit about categorizing those behavior types, but you also can look at them on a continuum, as you see in front of you. So they can range from those low-level, distracting, annoying, sort of irritating behaviors, all the way to what Peter was saying with this aggressive, potentially violent behaviors. They can go from low risk to high risk, disruptive to actual threatening, and then, as you had mentioned already, all of those different potential behavior expressions.
Absolutely. There we go. In addition, we also think about these things in terms of who it involves, what kind of folks are involved, different professions, sort of levels in that profession, et cetera. So there's this lateral versus vertical incivility. And lateral is this bullying or incivility between colleagues, often of the same level, but it can be slightly different. But yeah, colleagues of the same kind of level. And vertical is this bullying or incivility between individuals of different levels of hierarchy, okay, right? So attendings and residents, senior nurses, orientees, things of that nature.
Right. And although we generally see that one as being a trickle-down effect from someone senior to someone junior, it actually can reverse itself, and we can see it going in the other direction.
That's right.
So again, who's involved? So it can be within a discipline or role, nurse to nurse, physician to physician, tech to tech, but it can also span disciplines and roles, right? And it can cross care environments when you have difficulties between perhaps a specialty consult and the primary care team. Absolutely.
I do want to pause 1 second. There's a lot about physician, RN involvement, MD. When you see those, because that's what a lot of literature talks about, just put in your head what word you want to use, but provider, because APP, PA, nurse practitioner, CRNA, et cetera, also fall into that mix. So I just want to call that out as well and make sure those that are on the Zoom understand that that's really what we're talking about also, and y'all are included in this too.
Mm-hmm. And other specialties, pharmacy, laboratory, et cetera, can go on and on.
Exactly. So not only these behaviors affect not just those directly involved, but others in the background that could be observing and hearing about them in the aftermath. It can affect the team as a whole, entire units and floors, the culture can change when these things occur. And eventually an entire organization could develop a reputation for having these kind of problems. And there really is a trickle-down effect. There is research to suggest that poor interactions between providers and patients, certainly, but also these sort of cultural things that occur can have trickle-down effects to patients, families, and the communities.
Absolutely.
All right.
Okay, so that was sort of our quick shot across the bow. Here is what we're talking about tonight. And what we wanted to do, though, as Peter mentioned earlier, was to have a little bit of a day in the life. So we've taken the liberty to create a not so hypothetical hospital to talk about tonight. And we're going to follow this cast of characters. Their stories are really drawing on real as well as composite experiences. But what it does is it helps us to put all of these very clean definitions into the context of conduct unbecoming.
Exactly. So I wanted to introduce you to Happy Valley Regional Hospital. It's a 400-bed tertiary hospital, level 2 trauma status. There are residents, there's teaching going on. It's part of a larger Happy Valley health system, of which contains 8 hospitals spanning urban, suburban, and rural environments. And they have multi-ambulatory clinics in the region as well.
And so here is our cast of characters. First up, we have Dr. Wanda. She is a first-year surgery resident, and her goal is to be a cardiac surgeon. Now, she's also known for her skill being beyond her level of training. Next to her, we have Dr. Bill Gray. He is a pediatric surgeon who has been practicing for 30 years. Then we have our pharmacist, Mindy, who has been in practice for about 5 years. And Dr. Mike, this is his first year. He's a non-surgical resident who's rotating on ped surgery. We have Sylvia. She's a registered nurse, 6 months off of rotation, off of her orientation. And she is a floor nurse on our pediatric med-surg unit. Next to her, we have our charge nurse, Sophia. She's 20 years experience on the same pediatric med-surg unit. And then we have John, who is a 10-year experienced nurse who's going to be precepting a new graduate.
Okay, so those are the main cast of characters. There may be a couple of others down the line, but just wanted to give you an overview of who's going to be interacting with each other through the talk. Okay, so here we are at 6:30 in the morning at Happy Valley Regional Hospital, and yeah, that's right. Here we have the setting is Thursday. Mike is called by Dr. Gray to the OR, who realizes he hasn't obtained surgical consent for this 2-year-old baby, 2-year-old Bobby Smith's Wilms tumor removal. It's the first case of the day, and this is really, it's posted for 7. This is 6:30. Really the last item that needs to be completed before Bobby can be wheeled to the OR, induced, and the procedure starts at 7. Now, he was aware of a recent change in the consent process, but didn't really agree with it. Right. So that's going to come into play. All right, so Dr. Gray calls Mike and tells him to get to the OR stat. All right, Mike arrives at the circulating desk and finds Bill in the corridor.
I came as fast as I could. You wanted to see me?
Yes. Either you or Wanda neglected to consent the Smith family for Bobby's Wilms tumor removal. I need you to do it now because he's doing the OR for a 7 o'clock start. This is not the first time, and I'm sick of it. All right. So that's Dr. Gray to Mike. And so the questions we wanted you to think about is, are there any potential concerns that you might have at this point with not only the scenario or maybe the request itself? What might Mike be thinking, feeling at this point? Remember, he is not a surgical intern. This is, this is August, so it's August of his intern year. And what's Mike's response and why?
We'll give you a minute to just jot some things down, some thoughts in the chat. And Mary, feel free to stop us if you have anything you want to share at this point. Okay, so while you're doing that, we're gonna, oh, I'm sorry, Mary? Did
No,
you say?
sorry.
Okay.
I'm waiting anxiously.
Okay.
Okay,
All right.
all right, good.
Well,
All right, well, we won't
Okay,
keep you in suspense.
We do have, Dr. O'Gonnell says the surgeon is responsible for the consent since he's doing the procedure.
yes.
Excellent,
Okay.
all
All right.
right. That's
Mhm.
a good textbook, yes.
Yeah,
response, yes.
absolutely, absolutely.
Yep.
And I think we'll have an opportunity to talk about that a little bit more as well. I think what's interesting in these scenarios is we don't know what's really in Dr. Gray's mind or kind of that backstory there. And there may be things going on with Mike as well. But here we go.
What might be influencing his response?
Oh yeah, what might be influencing the response? I'm sorry. Yeah. Okay. There we go. Okay. So what happens next? Well, Mike refuses to obtain consent, but he does explain why. He said, "I'm sorry, but I won't do that. I'm not familiar with this specific procedure. I'm with the intricacies of the procedure, including the risks, benefits, alternatives, or the risks and benefits of the alternatives." And 2 weeks earlier, the surgical chief sent a memo that anyone not actively participating in performing procedure and does not know how to do the procedure should not consent for it. And he finally says, as a father, he's got a 2-year-old, it is morally and ethically wrong for someone like me to do this consent.
Uh-oh. So what do we think Bill Gray, Dr. Gray may be thinking or responding at this point? I mean, do you think that there's a right or a wrong here? And let's think again about the underlying context that may be at play. Again, as Peter mentioned, it's August, intern year. This is crunch time, right? This is 06:30. We've got a 7 o'clock start. And there's a lot of activity that's going on at the desk at this time.
And would it change your opinion about this interaction if you knew that his voice really started to rise and the folks at the circulating desk started here, heads were turned.
Yep, here we go again at the nth hour.
Right.
Mm-hmm.
Okay.
Yeah.
So, is this a completely one-sided situation, or were there things that could have gone better on either side? All right. Okay. So what happens? Well, in this scenario, Dr. Gray actually turns red, lips pursed, looks as if he's going to explode or actually hit Mike. But he turns around and walks away. Mike's left standing in the hallway, looks towards the desks, and realizes others witnessed the encounter.
Yeah, but the staff, of course, they busy themselves, avoid eye contact with Mike. And Mike just kind of hangs his head and leaves quickly, trying to find his program director.
Exactly. All right. So, again, if you want to throw anything in the chat, make some comments about that, please feel free. We can also come back towards the end if we wanted to come back to that scenario. There may be an opportunity to do that if you'd like. But that's the first scenario we want to put out there as we go through.
But Dr. Hill,
Yes.
so, we had some additional comments.
Great.
One referring to the intern doesn't have that experience, so it should be the attending, and that this is definitely an example of macro aggression, disruptive, unacceptable behavior.
Excellent. Thank you. Awesome. All right. So let's see what some of these behaviors look like in beyond this particular scenario.
Right. So we can look at them as either passive or active, although sometimes they sort of bleed into each other, right? So passive behaviors we generally think of as perhaps ignoring orders or withholding information, some ineffective or poor supervision, or non-collaborative attitude. Additionally, it's not just what we say, it's how we say it, right? And the nonverbals are a huge portion of that communication. So whether it's a body language, tone, voice, and then it could be defiance or insubordination. But then on the flip side, with active behaviors, you can see verbal abuse, violence, threats of violence, or violent acts. But then there can also be the gossiping, disparagement, patient advocacy gone awry.
Yeah, absolutely. The disrespectful communication, clearly is an active act. Undermining authority, micromanagement, and overbearing. This is actually, you may not think of it like this, but there can be supervisors or situations where the person is just always on their supervisee's back and won't let them really do their job. Just very overbearing. Taking advantage of a power imbalance, and blaming and shaming. And so we put in red the really
The clearly
egregious ones,
Yeah.
and I put in yellow, and there are going to be some others that were likely in play in the scenario that we just decided maybe, right? So defiance and insubordination, or was it?
right,
Right.
in the eyes of the beholder. Perhaps.
Exactly. Disrespectful communication. Maybe that last comment by Mike, maybe, but certainly the comment by Gray. He's sick of it. You guys do this all the time. There's a power imbalance there.
Yeah.
There's absolutely a power
Absolutely.
imbalance. Right. So a lot of different things we could talk about there, but we're gonna move on, and we're gonna meet some other folks.
Yep. So let's meet Wanda and Sylvia. So as you remember, Wanda is also PGY1, and so she is covering floor call right now. She's an aspiring cardiac surgeon, again, skilled beyond her level of training, and she knows it. She despises floor call and just wants to be in the OR. So she's actively trying to get into other surgeons' cases and really does not want to be receiving calls from the floor. At the same time, we have Sylvia. She's the floor nurse, and she is a post-op day 1 patient that was from 6 p.m. the previous evening. This is a 14-year-old status post-appendectomy patient whose mother has been voicing concern about his pain level, and he's maxed out on the PRN medications that have been ordered thus far. Now, the pediatric floor that they're on is multi-service, and they are receiving direct admissions from the emergency department, med-surg cases rolling out of the OR, and it is a very busy day. Now, she has tried to page twice to Dr. Wanda without an answer. And the mother is now adamant, I want you to get surgery on the line now.
That's right. So let's check out the conversation between the two.
So Dr. Wanda, I've now, on that third time, Dr. Wanda calls back. Okay. So Dr. Wanda, I've been trying to reach you because Max is in tremendous pain.
All right. Dr. Wanda has a little thought bubble before she responds. Why does the floor always call about pain medication? This issue is ridiculous. I'm going to lose my chance to get into a case. This is what she's thinking as she's saying, I didn't write for any stronger pain meds on the purpose. He shouldn't be having a pain that needs stronger meds after a minor surgery like this.
But his mother.
Just give him the damn meds I ordered. The mother is babying him. Can't you see that?
But
no, I need to be scrubbed into procedures this morning, and you're calling me for something so mundane and keeping me from saving lives. You need to feed and prep him for discharge like we planned. Don't call me again. Click. Okay. All right. So now what?
Yeah, big question. So we're going to move on to what happens.
So for physicians and nurses out there, just think about, I got a little anxiety when I was going through that, right? Yeah. I mean, that was not a good interaction.
Yeah.
Right.
And I think for many of us who perhaps were, early in our careers, you may have experienced something similar.
Yeah.
So Sylvia does what we would ask, which is turn to your charge nurse. So she turns to Sophia for help. Remember, Sophia is 20 years of experience, and she is an intimidating force on the floor. And she is tired of the frequency of new nurses coming and going, their retention rates, and dealing with multiple phone calls all the time. Now, Sylvia is a bit reluctant, in fact, to approach her because she's been chastised before by Sophia for interrupting her during calls. But Sylvia tries to get her attention and thinks she's actually paying attention. So she tells her story and says, look, I don't know what to do at this point. So Sophia, half listening, rolls her eyes.
Yeah, okay, I can't help you right now. This is one of those things you need to figure out for yourself. And then turns her chair away.
So Sylvia, frustrated and tearful at this point, heads to the locker room to gather herself.
All right. So some of you out there may have experienced some or all of this in your training and development. Hopefully not, but likely there's probably some of that out there.
Yeah.
All right.
We do have a couple comments in the chat.
Terrific. Yes.
One up, that the patient needs to be evaluated, authoritarian, a major patient safety concern. I wouldn't let her operate on anyone I love or myself, and very poor leadership.
Absolutely. I'm going to go back here a second. Yeah, absolutely. That's a great comment, because we were going to come back to this at the end of the we're going to come back to this at the end, but I'm going to address it right now because you brought it up. Notice that Dr. Wand Sylvia said, I've been trying to reach you because Max is in tremendous pain. Sylvia didn't ask for pain medication. She was informing Wanda that the Max was in pain, not that she was asking for pain medicine. Wanda went there right away.
Mm-hmm.
And so really wasn't listening based on her past experience, I guess. Okay. So yes, exactly. All right. So let's see what the numbers are.
Yeah, the numbers. And we reviewed a lot of stuff for this talk. So these are just some numbers that we found. Where prevalence over 70% of healthcare leaders identified disruptive behavior as a problem in their organization. And 63% of respondents to one survey had witnessed disruptive behavior leading to negative impacts on patient safety. Workplace impact, 96% of nurses in this one article from the Journal of Nursing Care Quality reported experiencing some form of disruptive behavior, and 17% saying that they were experiencing it on a daily basis.
Yeah.
Team dynamics, of course, these behaviors negatively impact that, right? It leads to breakdowns in communication and teamwork, which then lends themselves to patient safety issues. And at the end, right, there is also an economic impact, right? Millions of dollars lost due to increased staff turnover, absenteeism, and decreased productivity. So it really does affect many different sectors of our care environment.
And we're going to touch on that in just a couple slides, I think. Okay, we're going to see if this works. All right, hopefully this doesn't go to one of those commercial things, but we're going to try. All right, just a sample. So in researching this, when you find yourself on YouTube, there are hundreds and hundreds of videos and channels devoted to this topic by different presenters. Okay, and so these are two. This is Catherine Ann and Dr. Renee Thompson, and so used with permission. And so I'm going to just play this one, just a little clip from this. Shoot, I'm sorry.
We are sorry about the ad. We did our best, but
Does she even know how to pass that medication? Okay, new grad. Gosh, she takes forever to chart. I mean, why was she even hired here if she can't do her job? Yeah, what do you want? Okay, yeah, whatever. I mean, you're supposed to know what you're doing. Yeah, you are off orientation, so why are you still asking me questions? She'll figure it out for herself. She doesn't need my help. Go make the new girl do it. I mean, gosh, I've been here for over 2 years. Why should I be doing that? All nurses eat their young, right? So why is this any different? All right,
Okay, so even a couple of those examples, I think we just saw.
Sophia,
yeah. Exactly.
Church nurse, yeah.
Exactly. So we just wanted to give you that little snippet and that flavor, and then take just a brief look at this to make a point.
On this episode of Coffee and Conversations about Nurse Bullying, we're actually celebrating our 100th episode.
That's it. So 100th episode in this channel alone on this topic.
Dedicated to that.
And in fact, Dr. Renee Thompson, this is her career, and she lectures on this topic. She consults, etc. It just impressed me how many examples of this are out there and people trying to address it.
Right. And so these two examples happen to be dealing with the idea of nurse bullying. But I just want to reemphasize that this transcends nursing, right? This is in all of our spaces.
Absolutely.
Fortunately, and with all of our staff.
All right. So when you, as you all know, look on YouTube, then people leave comments. And so these are just some comments that I pulled out from some of these videos.
I've been a nurse for 15 years and I've been bullied and thrown under the bus multiple times. I gave up on nursing because it destroyed my soul.
Yeah. Another one, I'm not a nurse, but I'm a certified medical assistant and a CNA. And my God, the bullying is insane. I've quit my job. I quit job after job for bullying.
Yeah.
Oops.
New grad here, almost at a month at the bedside, and I'm leaving while dropping to PRN. But my peace of mind and my choices are mine.
Yeah. I've been a surgical tech in the military for 8 years now, working with a bunch of arrogant, pretentious adults who flip out over the smallest thing.
And rudeness of physicians toward nurses are not exclusively toward nurses, but just think, if these docs are rude to nurses, they probably are just as mean, if not meaner, to their own interns, med students, and especially the residents. Real story.
Yeah. So we mentioned the economic impact a little earlier, and here's an example of people just quitting. It's a tragedy, and this is what we're experiencing throughout, actually, particularly in the post-COVID era, throughout the U.S. right now.
So now we're going to flip back to the locker room. Now, Sylvia, remember, she's gone there to try and compose herself. And so she's feeling overwhelmed. She's sitting on a bench and she hears two other nurses who come in to the room. They're on the other side of the lockers from her. They don't know she's there, but she can hear them gossiping about Sophia. Sophia is at it again. I just saw her brush off that new nurse.
She never gets out of her seat to help anyone, always making herself seem busy, but it just isn't.
I wouldn't trust her clinical skills anyway.
I know. I can't believe leadership hasn't done anything despite all the complaints about her.
Well, she is the manager's buddy, so you know how that goes.
Yeah, I heard she found out who one of the nurses was that made a complaint about her, and now they get all the complex patient assignments when Sophia's in charge. Coincidence? No, I think not.
So they leave, and Sylvia is sitting there thinking about that and her previous encounters with Sophia, and she becomes convinced Sophia is not going to be able to help her. So she stands up, she heads back to her assignment, and she gets back to work, but she does avoid going back into Max's room, our API patient, at least for the moment.
And likely because she doesn't have an answer for Max's mom. She was unable to produce the surgeon, get an adequate response, and doesn't know what to say when she goes back into the room. All right. So let's look at some of the predictors and triggers of incivility. There's a lot of research that's been done about this within healthcare teams. And in this one, they did a systematic review of the literature. And they talked about situational and cultural predictors of higher incivility levels include high workload, communication or coordination issues, patient safety concerns, and lack of support and poor leadership.
And we've seen a number of examples of poor interactions. If we look at these drivers of incivility and bullying within the internal factors of the individual, we can see perhaps personality clashes or ethical dilemmas. Again, when we were talking about Dr. Mike and Dr. Gray, and communication issues as well. We can see maladaptive behavior that responds to stress, and everybody responds slightly differently, and it depends on, your experiences and what you come to the table with on any one day, but also learned response and observed behaviors of others and what is acceptable in a particular environment and what isn't. as well as personal issues. So in addition to the internal factors of the individual, we also have system level factors or the environmental factors, right? Role ambiguity. If we're not exactly sure what our role is supposed to be, and somebody else has a different idea, that can certainly cause some friction, and then that may lead to instability or patient ownership. Whose patient is this, right? Hierarchy and power dynamics we talked about before, resource allocation as well. And I know we saw some of this, it was very prominent in COVID when we're talking about masks and PAPRs and et cetera, and how that was really contributing to a lot of anxiety and concern and stress. Interdisciplinary collaboration, and whether it is healthy or not. Workload stress, organizational culture, and patient-related issues, such as mom right now.
Yep.
Patient, yeah.
A little bit more on the individual factors. People as individuals have different thresholds for bending and breaking due to stress, right? Including their response to fatigue. Fatigue erodes all of our kind of barriers, things we put up, and people have different breaking points. Risk factors that kind of lower the threshold for behaving poorly. In addition, individuals who exhibit characteristics of self-centeredness, immaturity, or defensiveness at baseline. Those that lack interpersonal coping or conflict management skills, and therefore they sort of have a lack of voice to be able to really express themselves appropriately. Some have developed maladaptive mechanisms of dealing with stress and irritation, which kind of results in a lack of control.
Right.
And finally, we alluded to this just a second ago, but role modeling, right, and learned behavior from mentors is extraordinarily important.
And we also have systemic factors, right, that increase of productivity demands, right? The patients keep coming, the orders keep coming, the need keeps coming. Our need for cost containment, for these and having these embedded hierarchies, as well as perhaps fear or stress from potential litigation. There can also be differences in authority and autonomy, differences in empowerment, or the roles or values of different team members. And as I'm sure all of you have experienced, you have this flux of daily shift changes if you're even in the clinic. So I've had the chance to work in inpatient, in ambulatory, in emergency, in austere settings, and across all of those care environments. There's constant shift and change. And then our interdepartmental support staff who may be outside of that clinical team and what they're bringing into the picture. So these high stress environments, though, can contribute to intimidating or disruptive behavior.
Absolutely.
Dr. Patch?
Yeah.
Yes, ma'am.
So Dr. Pradhan added that the patient suffers. Younger staff feel unsupported, leave the system, and that leads to economic impacts.
Absolutely, 100%. Yep.
Yeah, thank you. Now, organizations have a responsibility here, right? And some of it's a two-way street or a catch-22. Organizations can set the culture and tone, but organizations are made up of people. The people in the end are the ones that either carry that out or shift an organizational culture one way or the other. We know that there's an underreporting of incidents in healthcare. That's absolutely clear, and there is a fear of retaliation of calling out a culture. But again, that is a cultural issue within an organization that can be addressed head on by the organization. It takes time, though, but it can shift. There is a perception that the money-making physicians are treated differently. Up to 38% of those surveyed hold that belief, and there's likely some truth to that, although it is a little bit more complex than that one line. Okay. The Joint Commission does have 2 leadership standards to hold leaders accountable for this issue. EP4 is the hospital or organization has a code of conduct that defines acceptable and disruptive behavior and inappropriate behaviors. And EP5 is leaders must create and implement a process for managing disruptive and inappropriate behaviors. So how well an organization and a leadership does in these areas can help influence the culture of an organization.
Mm-hmm. Absolutely. And we know that frustrated patients are making healthcare workers' jobs even harder, as Harvard Business Review here notes. Patients are frustrated, trying to get access to the system, trying to get an appointment, waiting in the waiting room forever, challenges with communication. But that also, right, as our environments intersect, it can contribute to increased stress, increased pressure, and that can potentially lead to instability as well.
And it has been noted that post-COVID, there's been a sort of a decrease in patients and families' thresholds of incivility.
Right. Yeah.
And that's been, we've seen increasing verbal and physical threats and violence towards healthcare workers nationally post-COVID.
Although just to make a point that that's been happening for a long time.
Absolutely right. Yeah. But that in an organization's response to that can often make or break the staff's feeling for how much an organization actually cares about them.
Right. Yeah.
Which again is part of the climate.
Yeah. So let's go back to the ward. While Sylvia is struggling, on the other side of the floor, we have John. Again, he's been in practice for about 10 years and he's precepting a new nurse today. And they have a 6-patient assignment. So he huddles with his orientee about one of their patients, Sarah, their 6-year-old cardiology patient. Now, she has an SVT rhythm of unknown etiology and is waiting to go to the EP lab. Now, she's on a stable amiodarone drip, but infusion is due to run out in the next half hour. And the orientee tells John, look, I've been waiting on the new bag, but it hasn't arrived. And just at that moment, of course, the phone rings and it's EP saying, hey, we're on our way up. We'll be there in 10 minutes. So John says, all right, there's no problem. We got this. I'm going to call Mindy. We'll get this fixed. So he calls Mindy in pharmacy. Mindy has just started her shift and does not know anything about an amiodarone drip.
Exactly. All right. So Mindy takes John's call.
You want to do it? Or
all right, I'll do Mindy.
You do.
All right. Pharmacy.
Hi, this is John, nurse from 4 South. I'm taking care of 6-year-old patient Sarah. Hey, she's headed to the EP lab now, but her amiodarone infusion is almost empty and the replacement bag has yet to arrive.
Mindy says, look, I just got here. This wasn't my fault, and I have no idea what you're talking about. Have you looked in the tube, in the med bin, in the med station?
Look, I understand shift change just occurred, but this kiddo still needs her amio. And yes, we've looked everywhere and it isn't here. Can you just send us up what we need?
Mindy says, you 4 South nurses are constantly misplacing meds. The system says the amio was made and delivered. Look harder. Otherwise, just send the kid to the EP lab and let them work it out with their pharmacy team.
Click.
When he hangs up.
Yeah.
All right. So we are going to move on for that, but just keep that in the back of your mind or ruminate on that for a bit. And later in the day, back in the OR.
Wanda's coming out of an OR. She had been in a case. And she's walking toward the circulating desk and, it was a pretty good case. She's coming out of there feeling pretty good. But all of a sudden, there's this commotion in the hallway with this stretcher quickly being rolled by. A lot of people around the stretcher. And she realizes one of those is Dr. Gray. And then she realizes that the patient they're wheeling is Max. That's that post-op appendectomy that she was paged about earlier. So they whisk by. And as she continues and she approaches the desk, she overhears 2 people talking. Yeah, apparently the nurse called the intern multiple times about the patient, but was hung up.
I wouldn't want to be that intern when Dr. Gray gets out of the OR. Okay. All right. So let's move on. All right. So conduct unbecoming is dangerous in several ways. And I think we're seeing some of this, but it undermines the trust and reputation of an organization, right? There's impact on decision-making and judgment. I think we've seen some of that. There's a risk to safety and security. We've certainly now, I think, seen some of that. There's a culture and organizational damage as well, particularly as this becomes embedded and there's a unit or an organization that becomes has a reputation for this kind of behavior. There are legal and regulatory consequences in these professions with strict codes of conduct. It may lead to legal or regulatory sanctions, including fines, license revocation, or even criminal charges if the behavior violates the law. And there are clearly personal and psychological impacts as well.
And so this meta-analysis that came out in the Journal of Advanced Nursing talked about the prevalence, looked at that of incivility in hospitals and the effects of it on patient safety culture, as well as the outcomes. And what they found was it is associated with various safety outcomes, including near misses, adverse events, reduced procedural and diagnostic performance, medical errors, as well as mortality.
In this systematic review, looked at the impact of this interprofessional incivility on medical performance, service, and patient care. In summary, there's the systemic nature of incivility suggests the need for systemically designed intervention. There's a clear relationship between these two, and if it in its systemic nature means there has to be a systematically and a systemic design interventions. Okay.
So now we'll hear again from Dr. Thompson on some additional impacts.
Every day of my life, someone reaches out to me asking for help. I mean, we are hemorrhaging really great nurses, physicians, and support staff to bad behavior. And leaders can no longer afford to use silence as a strategy. There's a hidden villain in healthcare. We don't acknowledge it, but we all know it's there. Bullying and incivility are alive and well. The truth is, healthcare today has gotten more and more complex. Increasing demands, decreasing resources, burnout, bullying, and incivility have changed how leaders need to lead their teams. And that's where I can help. The demand for this work has really been tremendous. And, you know, I will say that I was a little surprised.
There we go. All right. Okay. So just wanted to, again, highlight that point and all the work that's being done nationally around this. All right. Where to next?
Yeah. Well, where do we go from here and what do we do to fix it? So we've already highlighted the conduct unbecoming posing significant dangers to that culture of safety. And it's important to address and prevent conduct unbecoming, right? Because if we don't, we're setting our good teams up for failure, right? We're going to have patient safety issues. We're going to have professional standard violations. We're going to be, the entire system is going to be affected. So what we need to look at is our policies, our education, our training, our commitment to ethical behavior from all the health professionals, as well as the community at large, and the accountability piece to that. And that can be very challenging.
Absolutely. There are social and ecological models that one can look at to frame this appropriately.
Yeah, and again, the social ecological model, this is a systems level theory, right, that considers how individuals and their environments interact to shape behaviors. Because the behaviors both affect and are affected by various contexts, right? And so for our talk today, we're really just focusing on those three areas of the individual, the interpersonal behaviors, and then the institutions and organizations. And for an individual, it can be influenced by our beliefs, our knowledge, our attitudes, other behaviors, our feelings of self-efficacy. If you think back to Sylvia, the nurse, and whether or not she feels like she can be effective in caring for Max, our motivation and emotional regulation. Then when we talk about the interpersonal dynamics, these are, of course, relationships with peers and colleagues, our social networks and support systems, the cultural context in which we work, and just communication patterns and social norms. And then to the institution and the organization, again, these are all interacting with each other, but this could be the clinic, the unit, the floor, the hospital. And this involves our policies, our practices and procedures, the physical environment in which we work, and our organizational culture. I know when we moved from our previous ED into our new ED, we went from a 10,000 square footprint to a 40,000 square footprint. And that had some repercussions, right? People were tired. Things are spaced a lot farther than they used to be. And it takes some time getting used to that change. And that does cause stress.
Absolutely. Let's take a look at some of the individual actions then. I think from Choosing Civility by PM Fernie in 2002, looked at a number of individual-based situations. So being civil means being constantly aware of others, right? And weaving sort of restraint, respect, and consideration into the fabric of that awareness. And one of the things that prevents us from doing a good job of listening is that instead of focusing on other people, we focus on ourselves and our own needs as we're having a conversation or a dialogue. You've got to get out of your own head and really be thinking about the other person. Having civil conversations require the ability to consider that you actually might be wrong and the ability to admit that you don't know. And that can be hard sometimes in the healthcare setting. Although I think I say that in the clinical area 3 or 4 times, maybe 10 times a day. Apologizing is one thing, right? But you know that I'm sorry that you feel that way. That's not an apology.
No.
And employees should expect to work in a civil workplace, right? And I mentioned and I commented on organizations' sort of responsibility in that realm. But the corporate responsibility doesn't erase the individual responsibility, because what is a corporation but the addition and accumulation of all the individuals, right? So it does not absolve the individual responsibility either.
Right. And so what we did was we went ahead and pulled our own code of conduct here at Hopkins Health System. I wanted to know what it says.
Yep.
And so we just take some excerpts from that. It talks about the organization setting individual behavior expectations, like treating patients, families, and other workforce members with respect, civility, and dignity. And we have a couple of bullet points down here so that it's communicating what is the expectation of the leadership of the organization. They're setting us up for success, hopefully, in this.
Yeah. And then it goes on and talks about the role model of communication, collaboration, and teamwork. So it sort of sets the problem. What is it, and how are we going to approach this as an organization and individuals as we do our work?
And then these are just a few others. This is really tying in because we have a tripartite mission here of patient care, teaching, and research, and how we are responsible for our behaviors across all of those and holding up high ethical standards. Again, giving us some expectations for what the organization wants.
Absolutely.
From its workers, yeah.
But then we're going to go on and look at maybe some tools that can help.
Mm-hmm. So I'm not sure if any of you online have taken team steps before. It was a collaborative work with the Agency for Healthcare Research and Quality, excuse me, and the Department of Defense many years ago. They're on, I think, 3.0 version now, and they do offer various tools because we can learn to communicate better. We can learn better teamwork skills. So here are just a few. This is talking about situation monitoring. We as individuals need to be aware of what's going around us, right? And then be able to communicate that and adjust so that we as a team can maintain that shared mental model. And parts of those are these other two to the right of that, the STEP mnemonic, which is thinking about the status of the patient, but thinking about the team members. Are they tired? What's their workload? Our task performance, our stress levels. Are we skilled to be able to care for that particular patient? As well as the I'm safe checklist. And so thinking about things that may be affecting yourself as well as those on your team and your friends around you.
And we were in the sort of personal section. You think about you as an individual. So these are sort of individual related interventions. But now we're going to go on and talk about some of the interpersonal actions and make some definitions, and then maybe some tools. So communication is more than just talking.
Mm-hmm. Right.
It's there's a communicator and someone you're communicating to, right? So you're encoding things and you're going to speak, and then the person on the other end is going to try to decode that within their own cultural context, the communicator within their own social context, and there's this relationship between these two that can inhibit the actual meaning that one person is trying to get across to another.
Absolutely, yeah, and a lot of noise, right? Noise from the environment, perhaps even from what's going on in our own heads at any one time. Right?
Exactly.
So a couple other tools that Team Steps offers is this idea of closed loop communication. What is that? What are call outs? As well as a potential way of communicating critical information called SBAR. You may be very familiar with this, but it's a way of structuring how we're presenting any particular situation. What's the situation? What is the background? What's the assessment? And what am I recommending? Keeping it concise and being able to share what are those really salient points without going off into tangent, right?
Exactly. And there are tools that can help the team. And there are conflicts in teams, obviously. And depending on what those conflicts are, there might be different sort of tools that you can go to try to help resolve those conflicts before they start. So there's informational conflict. You know, we have different information, and there's this two challenge rule, or interpersonal conflicts, hostile and harassing behavior. And there's this desk script that we'll touch on now.
Right. And so the two challenge rule, again, I'm thinking back to Sylvia and Sophia, when Sylvia is trying to get Sophia's attention. And she thought that she had her attention, but there is the ability or the expectation that if you're not getting the response back, you may think, okay, they didn't get the communication that I intended them to. And so this gives you just some options for, okay, well, you are expected to make sure they're looking you in the eye, and you're going to repeat it again. And hopefully it changes what response you get. But if not, then there's an escalation for that. So again, various tools from Team Steps to help with some of those communications.
All right, let's go back to our scenarios. All right, so towards the end of the day, we have Dr. Gray there. So Bill walks into a physician workroom off the OR, and he finds there his long-term friend and colleague, Fred. You would not believe the day I've had with these interns, he says. He relates to Fred the interactions with Mike and Wanda's ignoring Sylvia's concern. So both those things that happened. And Fred responds,
well, you know, Mike is right. He's a rotating EM intern. Plus, the chief did send out that memo. He was put in a really bad situation, especially being accused of not doing his job. I'm sure you already had a long conversation with the family about the surgery, but did you explain that to him? And then in terms of Wanda, like, this is actually not the first time this has happened with her. Have you taught her why floor call is important, or even how to take calls from the floor?
So Bill sits down and remains upset and irritated. But after a while, asks Fred what he should do now. So I had alluded to this earlier, but you know, the surgical consent process, right, isn't just about the form. It's about actually spending that time and having that exchange with the patient. And so in this case, I think on reflection, Dr. Gray had done that and just wanted to get that form done.
The pesky form.
Just the pesky form. And so it's an administrative thing that the hospital requires.
Right.
In his mind, he had the informed consent discussion, but that's certainly not what Mike heard or understood or believed or had any inkling about, regardless of whether or not Dr. Gray's belief is right or wrong.
Yeah.
So people come at these things with different assumptions and different perspectives.
Absolutely. And just to touch on a couple additional tools that might help, and these are task assistants, thinking about each other as well. And maybe I can come and say, hey, maybe I only have 5 minutes, but can I get those labs for you? Or can I do something that's within that amount of time? But really to try and help offload from each other that heavier workload from time to time, as well as a way of addressing formative feedback, which again, with Dr. Gray, he is about to have with his interns.
Correct. All right. So there isn't, as we alluded to before, there isn't just those two people that are interacting. There are bystanders. There are people that are around that often sort of hear this in real time, or maybe in afterwards, like actually Fred just did. And so think about the staff at the circulating desk, as well as the nurses in the locker room, right? They were bystanders to the behaviors and therefore really could influence the situation, but really none of them seemed intent on making the situation worse, but we're also trying to prove things either. So the bystanders can be sort of classified into 4 different groups. There's sort of the active constructive group, that those that actually step in and actually address the behavior and try to improve it. There are those that are kind of the passive ones that they recognize it's harmful and they're sympathetic kind of afterwards, but don't really directly address the behavior.
Right.
On the other side, there's this sort of passive destructive group that sort of avoid the behavior completely. Maybe like some of the people in the circulating desk. But then there's the active destructive, those that actually join in and just make it worse.
Yeah, and we did not include one of those in this particular scenario, but they actually do certainly exist, and we wanted to make sure that we call that out. Now, in a healthy environment, we want our bystanders, anyone in the area, to feel confident and empowered to actively and constructively intervene. But again, this takes work. It takes cultivation and training and organizational culture supporting it.
Right. Yeah.
And there are a variety of resources and training options out there as well. And this is just an example of a tip sheet from the American Psychological Association. And they, in fact, actually make a distinction between a bystander, who they define as someone who witnesses, maybe ignores and disrupts disruptive behaviors, from upstanders, who are those that intervene, that active constructive that was in the previous model. But again, just wanting to stress that those witnessing disruptive behaviors as well are often affected by them. And depending on their background and experiences, they may not feel that intervening is particularly safe. So again, a thoughtful approach to a needs assessment for the organization and the training implementation is really needed.
So let's look briefly again at this concept of role modeling. We've actually touched on it a couple times, and let's see what the MLH doctors in New Zealand have to say.
I think from time to time, we've probably all witnessed an event that we feel is wrong and counts as harassment or bullying. Healthcare is a high pressure environment, and sometimes in the high stakes care of patients, some people can lose their cool and can say things that they later regret.
Many of us have been brought up in a culture where that stress leak and that offloading on a junior colleague has been accepted, and that's the culture that we've grown up with. As we all know, bullying is perpetuated down through the ranks, essentially, by the behaviour that our junior staff see and then model themselves. So if we bully our junior staff, then they in turn will then bully their junior staff when they become consultants.
Most of it.
Yeah. So I think that's absolutely true. I think as attendings who teach, we bear a responsibility that every time we walk out on the floor, everyone's looking at us, and how we behave is modeled, whether or not we realize it or not.
And our nurse leaders as well.
Yep, absolutely. All right, so let's look at some of the organizational institutional actions in a couple of different categories.
So we can look at it from the prevention model, right? Primary, secondary, tertiary prevention. So primary prevention being, of course, before problems start, and this is talking about the prevention training. How do we tailor it for your particular audience? And also look at our policies and procedures around that. And so these are just some examples of what could be involved in a primary prevention plan.
Yeah, and this is a lot of the groundwork that needs to be laid
Yeah.
as an organization moves forward. But then there's the secondary prevention. What happens right after an event occurs, right? And you need to have a playbook. So you approach this appropriately. You need to take all the allegations reports, seriously. Take appropriate actions, inform leadership, remain neutral, etc. So there are all of these important points that need to occur when you respond to an event, and that's the secondary prevention. Okay.
And then we can move on to a tertiary, right? We are trying to mitigate any lasting effects and prevent future occurrences. So reinforcing our values in multiple venues, conducting those follow-up assessments, and doing that in a timely manner so that folks know that we're being responsive, right? Incorporating the lessons that we learn into subsequent trainings, reviewing our current policies. Maybe it's time to revise something. Maybe it's time to update something. And to look to our climate assessments, because many of those will give us some really great insights about how we're doing.
Absolutely. And then there's the concept of briefings, huddles, and debriefings. They're all slightly different, but a briefing really is about what's going to happen going forward. Let's all get on the same page. Let's have the same mental model, and then go forth. All right. A huddle.
A huddle is just going to be, okay, look, time out. We need 10 seconds. I've seen this done really, really well in our emergency department, right? Yeah. We got 50 in the waiting room. We have 75 beds full. We have 30 admitted patients boarding. We need to just get everybody around the desk and let's 10 minutes. What do we need to do? And then we may have to change our original plan.
Yeah, exactly. And then a debriefing. A debriefing is really pulling the team together after an event. And some EDs, some critical care units, et cetera, or even ORs will have planned debriefings after every single code or trauma activation, et cetera, just to go through and see if anybody has any thoughts or ideas, even if nothing apparently went wrong, because there's always things to learn.
Right. And they can be very quick. It can be what went well, what didn't go well, what can we do different or better next time.
Exactly. And I think what's important is once you put that kind of thing into place, people start feeling more comfortable to speak up about the more difficult things.
Yeah, absolutely.
All right. So in this case, there is an end of day briefing. The CMO and CNO together have been trialing an end of day briefing with the main clinical services who are caring for patients on this particular peds med-surg floor. There are medical and surgical services, nursing, pharmacy, radiology, and laboratory are all represented. And they've asked the nurse manager and medical director together to facilitate the discussion. And it's structured around what went well and what we could have done better and how to improve, with every service being given a chance to offer observations. It's intended to be non-accusatory, non-judgable, and non-judgment, but it can be difficult.
It can be very difficult.
And over the first few weeks, maybe not a lot happens. Maybe there's not a lot shared.
Yeah.
But it takes some time.
You build trust.
You build trust, yeah, exactly.
Yeah. So it becomes clear from the debriefing that there were 2 unexpected events on the unit that need more exploration. So the nurse manager begins, all right, let's talk about Max. So Sylvia says, okay, well, I tried to relay my concerns, but I really don't feel like I was heard and might have been misunderstood. But upon further reflection, she does offer, maybe if I had put my communication in a structured format like SBAR, maybe it would have been decoded easier.
Exactly. Now, Wanda does offer a response, but she was coached beforehand by Bill before going to the debriefing, prompted by his interaction with Fred, that she was late for the OR and jumped to a rapid conclusion that the concern was about needing more pain medication, not that there actually might have been something wrong. Also, she offers she didn't give Sylvia the space to explain the issue properly, and she used words and tone that were pretty inappropriate.
Right. And Sophia does interject that she said, yeah, Sylvia came to me for help. I was taking a bunch of calls. I really didn't listen to her plea for help.
All right. So these sequence of events led to an emergent take back to the OR rather than potentially a planned and a take back. Okay.
And now let's talk about Sarah. So John relates the issue with the amio infusion and offers that he could have paid closer attention to the critical infusion and his preceptee's attempts to find the new bag.
Yeah. Minnie feels horrible about the situation. She apologizes, accepts responsibility, offers that the context, this was the fourth call she had gotten about missing meds from the night shift, that clearly something went very wrong, which needs to be evaluated. And she was triaging and relied on the fact that, at least in this case, the system said it was delivered, but it clearly wasn't.
And then after the debriefing, Bill pulls Mike aside to talk a bit about the consent issue.
Consent issue, yeah. And we can come back and talk about that if you wish, but we have touched on that a little bit. So let's go on and talk a little bit about some interventions on the ground. And we talked about a lot of different contexts to individuals, interpersonal, organizational, et cetera. But how does this kind of look on the ground? And it really starts that with values backed by actions, right? Values that hire, yearly evals, and training applies to anyone.
Mm-hmm. And again, the role modeling, that leaders are modeling professionalism, respect, and teamwork at all times, because remember, what we permit, we're promoting. Right? So resist that normalization of deviance in behavior.
Building a safe, transparent, just culture that we alluded to involves clear expectations, human error, at-risk behavior, and reclass behavior. Human error occurs. And part of a just culture is understanding that, but setting expectations and being able to be transparent about our mistakes.
And then building on our emotional intelligence, these coaching opportunities, avoiding that amygdala hijack, right, where our lizard brain kind of takes over. So the deep breath, count to 10, et cetera. It sounds easy to say. At times it can be really hard to do. But again, practicing that can be very helpful.
These briefings and huddles are really important, and debriefings. Information sharing, shared mental model, clarified plan, role clarity. Everybody's on the same page, on the same team. Really important.
Mm-hmm. Using structured communication like SBAR, using critical language like the cuss words, the I'm concerned, I'm uncomfortable, this is a safety issue, etc. But avoiding the word you always, and the finger point that always accompanies that, right? But really taking it from a position of help me understand. I see this, I'm feeling this. Let's talk about it.
Yeah, and using some scripts can be important. I think it takes a little skill to do it in a way that doesn't sound so scripted and stiff and unnatural. But at least understanding these concepts of description, express, affect, the behavior, etc. And feedback. A culture of feedback helps remove the stigma of criticism or correction. So having these huddles, briefings, and then planned feedback over time reduces the anxiety, it normalizes it, and it builds trust.
Absolutely. And those debriefings are really important. I know myself, a long time, I would kind of push that up. I don't have time for that. I have all this other stuff that I have to do, right? And that is the reality of working in healthcare today. But they can be quick, and they can be done really well in a short amount of time. So I really do. I really recommend that.
All right. So in summary, so conduct unbecoming is prevalent. We know that.
Yeah. And day to day, those more insidious behaviors, some of which we talked about today, are actually a lot more common than that verbal and physical abuse that we hear about.
There are both internal and external factors, right, that contribute to this problem in healthcare.
And the issue is system-wide. Actually, I would argue internationally, we are dealing with these issues. And that's contributing to our healthcare issue.
And as a result, it takes both an organizational and we emphasize a personal commitment to address the problem.
We need this system, evidence-based, thoughtful approach to it. And the saying of what an organization permits, it promotes, really does hold true for this case.
All right.
Woo. We have some time, hopefully, to talk.
So happy to take questions or have a conversation. Please. Yep, I can stop sharing if we wish. There we go.
That's okay. Thanks so much. It's a super presentation. Of all the good folks on the call, we have about 100 altogether. We have comments, questions, concerns for our two speakers tonight. Please speak up or send it through the chat so Mary can relay it. Dr. Don, I see you lit up.
Thank you. Amazing presentation, Dr. Hill and Dr. Batch. Appreciate that. Hopkins brings a lot of memory. I used to go to the 1991, 92. I used to go to the Saturday morning conference there.
Oh, yes. Yeah.
Yeah.
And first 3 rows were all people with the gray hair. Now I have.
That's right.
Yeah.
Grand Rounds in Turner, right?
So definitely what you're talking about is a very time pertinent, and younger staff, younger colleague, younger medical student coming in, and there is so much of issue with inclusive ideas are not accepted, and people in the upper level always look down on medical students and residents. Not only that, patient also look down on the resident and student also. Question I have is, the situation you described is very about the hospital centric, but then most of the care nowadays being delivered at the ambulatory care setting.
Yes.
So I guess question is how to interact with those situations when you have one-on-one time with the patient, and in the room as well as in the group setting, how to make the team and have that I have your back attitude. And you pointed out rightly is the organizational impact from the top down versus bottom up approach. So how do you think we should reach out, educating our younger generation, i.e. medical student, resident, and then there's a physician workforce, then the APP, and then front staff in the administrative office in the ambulatory care center. What are the approach you suggest? Because there are multiple tiered approach we need to reach out to.
There are multiple tiered approaches. You're absolutely right. And we actually meant to pause for a moment and emphasize, we said all this within the hospital, but boy, healthcare is delivered out everywhere in the community and in the ambulatory setting. And so these concepts apply there as well. The scenarios are just different. Yes, you're absolutely right. I think these issues, and you are seeing some of this, need to be interwoven into medical school curriculum as well as resident curriculum. Boy, the problem is what I had to learn when I was a medical student is now a fraction of what the available information that medical students now have to learn. I mean, it's really quite remarkable. Yeah. But we are learning that time spent on these kind of topics is actually quite critical in teaching some of these techniques, right? I mean, the students and residents, you are absolutely right, are often on the receiving ends of some of the attitudes that you just described from patients. I mean, I've had patients not wanting to be cared for by a resident, and I've had to intervene. I've walked by a room and someone yelled out, "I want the gray-haired doctor." Right? It made me feel great. But you're absolutely right. You want to comment?
Yeah. And I know working ambulatory as well, we had the opportunity to have some team building work. And that was not just in the silo of the physicians doing their thing and nursing doing their thing, et cetera, but really bringing everybody together. In my particular situation, we actually did a Myers-Briggs on everyone and put that up at the very end so that we could see how we are actually a little more similar than we are different. That amazingly, I found improved our communication. I wasn't quite expecting that, but that is really what happened in the end.
I think the SIM Center here, I think between the School of Nursing and the School of Medicine, correct me if I'm wrong, but I think they've actually done clinical scenarios with medical students and nursing students together in the SIM Center, which I think is just phenomenal.
Yeah, no, absolutely. And you can weave these into any SIMs, and they don't have to be high fidelity SIMs either.
Right.
Yeah.
Thank
Did
you.
that answer your question?
Yes. Yes. Actually, I am also in the Virginia chapter ACP. I'm DEI chair. We were talking about how to educate our resident, our medical student, not only that, our APPs, because they are part of the healthcare collaborative team.
Yep.
So we all have to approach together. And then not only that, my front staff, my nursing staff, everybody has a role to play. So have to have what is called I have your back attitude. Like I made a note in my comment section, guidance, support,
Yes.
learning, and then educating. And then say, I have your back. We are here together for the patient care, because the patient is happy and healthy. That's our goal. So thank you for the presentation. It was wonderful.
Thank you.
for your comments.
Appreciate it.
Well, we have other comments. Please speak up. Mary, is there anything in the chat?
No, there's not.
Dr. Moore, will you share this video presentation? We can share with people who did not attend.
Yeah, we have it available. As I said at the opening, we record our programs, and these are now available through our Sovah Health website under the Education tab. From anywhere, you can click on them and listen and watch. We don't provide CME credit for those because we don't create them as what's known as an enduring material. And then if you're in-house, if you're working from a Sovah computer or device, if you'll let us know, we can give you an internal link. But no, we record these, and we very much hope people will make use of them. Absolutely. Okay, well, we're right perfectly on time tonight. I can't thank Dr. Hill and Dr. Patch enough for doing this. It was just outstanding. Again, we had 100 folks on the call, including ourselves, and this was just spot on what it should be. We thank you so much for doing that. For everyone else on the call tonight, we hope you'll rejoin us September 4th, which is the first Wednesday in September, and we'll talk about inpatient care a bit, and following that, an update on adult vaccinations, annual vaccinations. We'll be sending that out. We hope you all have a great evening. As we tell the residents when I gather with them, please be careful out there, and we wish you a good evening. Bye-bye. Good night.
Thank you.
Thank you all.
Thanks, Dr. Patch. Thanks, Dr. Hill.